Okay. Hello, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to focus on MCI, mild cognitive impairment. A lot of you write to us when your loved one or you've just been diagnosed, wondering, what does this all mean for the future? Or does this mean I'm going to get Alzheimer's? So we thought we would tackle this question head on with Emily Paolillo. She's from UCSF, and she is a doctor there who is an expert on MCI. Emily, thank you so much for joining us.
Yes, thank you so much for having me.
Okay, now I am just going to say this is such a common question. We hear when people are first diagnosed with MCI. And I have to say, doctors tend to give that diagnosis first, no matter what the situation is. That's very, very common. So let's just start with, how do you diagnose MCI? And then we can go a little bit into its difference with dementia, et cetera.
Yeah, that's a great question. I think, this can be a really confusing term because oftentimes, physicians might not give a lot of background and context and, to what this really is. So, Deborah, as you said, this is mild cognitive impairment. And this term is really used to characterize a mild level of cognitive impairment. And what does that mean exactly? So typically we have some criteria to determine, what is mild versus what's more severe. And, at the more severe stage, we would call that dementia. Both of those things characterize the severity of cognitive impairment. But MCI is really defined by a mild level of cognitive impairment where you can still function independently. This means that maybe the person is noticing cognitive changes. Maybe during an evaluation, we pick up on some mild difficulties during cognitive testing, whether that's comprehensive cognitive testing or a cognitive screener, but that they can still function for themselves independently. And to determine this, clinicians like myself will often ask about things that we call instrumental activities of daily living. And these really include things like managing finances, managing medications, being able to shop independently, preparing meals, completing household chores, navigating transportation and getting places independently. And so, if there's evidence of cognitive impairment, but you can still do all of those things independently, then the person's cognitive difficulties are characterized at this level of mild cognitive impairment, or MCI. And then if there's, go ahead.
No, I was just going to ask, so there's a lot of reasons why our memory doesn't function as well as it did. I mean, normal aging, some people, when they're having hormonal fluctuations during menopause. When we think of MCI, though, is that like when you enter dementia, it's a point of no return? Or are you in this gray area where, okay, you're having mild cognitive impairment, things could get better?
Yeah. So I do think it's a gray area, and it really depends on what your doctor is thinking. What is the cause of the MCI? As you're describing, lots of things can cause cognitive change. Some of which are pretty normal, just like normal aging. Age is related with a lot of declines in functioning that are pretty typical. But there are other things that can cause cognitive changes, and MCI, that are related to disease, one of which being Alzheimer's disease. There are lots of other neurodegenerative diseases that can cause MCI, and other health conditions as well, things like stroke and other forms of cerebrovascular disease. But the course will really depend on what is the underlying cause of those changes. So as you described, things like hormonal fluctuations, sometimes even people are having difficulties with sleep that really affect their cognition. Sometimes there's imbalances in vitamins and other metabolic processes. And when those things are underlying the MCI, those have potential to be treated. And sometimes people can see an improvement or at least stability.
How do you tell the difference? A patient comes in and says, I'm experiencing some memory issues that are outside the norm. Are they treated like people who you may think have dementia, given those, those preliminary screenings like the MoCA test? Like, tell us about that diagnostic process.
Yeah, there's lots of different forms of evaluation and lots of different tests that we can give to try to tap into what is causing this MCI. So I'm a neuropsychologist. And what that means is that I'm, in the clinic, I'm the one who's administering cognitive tests and interpreting people's performance on these different cognitive tests. We tap into all sorts of cognitive functions like memory, attention, processing speed, language, executive functioning, which is really complex, collection of higher order thinking skills. And based on people's performance in all of these domains, people have different patterns of strengths and weaknesses. And some patterns indicate, a higher likelihood that it may be caused by a neurodegenerative disease. Other patterns, for example, might indicate that things may be, their weaknesses might be caused by other, maybe more treatable things like sleep or depression. And in addition to that, I work really closely with neurologists who are the people who more closely manage the long-term care of our patients. And they'll often order additional evaluations and diagnostic tests. For example, getting a brain scan, brain MRI, a blood draw, or a lumbar puncture to examine, what proteins are existing in these fluids that we have that can indicate whether or not a disease is present.
So you're talking about things like plaque, or
exactly,
like beta amyloid plaque, which we know is a beginning hallmark for Alzheimer's. Okay, so I have a question. I kind of want to flip it around. So we hear from a lot of people that they've received, and honestly, it's almost like it's MCI and it's not the dementia or Alzheimer's word, right? But there's a lot of confusion over what exactly does this mean. So I'm going to flip the question around. As a doctor, what would make you give someone an Alzheimer's diagnosis early stage versus MCI, or would that just not happen?
Yeah, I think, we can absolutely, when we see someone make informed and educated hypotheses that would lead us to say, okay, we think this is MCI due to Alzheimer's disease. And those types of things would be, the collection of all the things that I just mentioned, right? For example, Alzheimer's disease most commonly manifests as difficulties with memory. It doesn't always, actually, so we want to be aware of those things too. Sometimes it can manifest as difficulties primarily with executive functioning or even visuospatial problems, but most commonly it would be difficulties with memory. So, if I'm seeing a patient and I see that on their neuropsychological testing, their primary difficulty is in memory, and maybe there's some weaknesses in other domains as well. And then I pair that with other findings. For example, on MRI, one of the brain regions that most commonly is associated with memory difficulties in Alzheimer's disease is our hippocampus, or, also within the medial temporal lobe. So if we see damage to that area on a brain MRI in conjunction with memory problems on testing, then we have more evidence to say this is likely due to AD. And then on top of that, we'll order these additional diagnostic tests through the blood or the cerebral spinal fluid, looking for Alzheimer's disease proteins. And then at that point, we can say, okay, we really have evidence to say that this MCI might be due to Alzheimer's disease.
So the scan is a tricky one because, obviously, now there's blood tests, but those aren't usually available to the general public unless they are participating in a trial. I know some clinics are using them now, but it's not mainstream yet, right? They're still very new technology. So we have been told that PET scans are the best way, or a spinal tap, to determine whether or not there's plaques and tangles, right? And that was kind of the gold standard. And we're watching the space of blood tests. But I've always been curious about an MRI because that's kind of like the first line of screening. So what exactly are you looking for in that MRI that will say, oh, I mean, because don't our brains all kind of atrophy as we age a little bit? So what's the difference between, oh, wow, this is dementia, and, oh, this is just normal aging?
Yeah, that's a really great question. And it also depends on who's looking at this brain MRI too. The first person who usually looks at a brain MRI is a radiologist, and they're looking for really glaring issues, things like, a tumor or other abnormalities. And then when it gets to the neurologist, especially at a specialty dementia clinic, they have a much higher level of detail to look at these patterns of atrophy. And you're right, absolutely. When, as a person ages, there's going to be, more atrophy or decreased tissue in the brain in general, because that's just what happens with aging. But seeing, sort of a holistic view of the brain and seeing that some parts are more atrophied than you would expect, given sort of the rest of the global atrophy in the context of their age, that really hints to a neurologist that something extra is happening in there that is not just due to normal aging. So for example, even if the brain has sort of general atrophy, but those medial temporal lobes, those hippocampi are doing much worse than the rest of the brain, then that can be a sign.
That actually is a really great answer. I wasn't thinking of it that way, but thank you for that. Now I'm going to throw the question around that we get all the time. I've just been diagnosed, or my loved one's just been diagnosed, and like, what percentage of cases eventually become dementia? Obviously Alzheimer's being the most common.
Yeah, that's a great question too. I mean, it's hard to say exact numbers because it is so dependent on what the MCI is looking like, right? So MCI is just this sort of broad term that tells us about the overall level of impairment, but it doesn't tell us about the symptoms that people are experiencing and in what other context, right? And we've already discussed, there are so many contexts that can alter somebody's cognition that may be treatable, like mood, sleep, other cardiovascular risk factors, things like that. But in the context of, it being an MCI that are, your providers are really suspecting might be due to a neurodegenerative disease, there is a much larger risk for that to progress to dementia.
Do we know what the rough percentage is of MCI diagnosis that leads to dementia? Do we know that?
There may be epidemiological studies that have, estimated those things. I'm not totally sure on the numbers of that. In our clinic, we take things at such a person level approach that, we're sort of taking in all these context factors that these larger epidemiological studies don't necessarily focus on.
So what is your recommendation to the patient population and their loved ones if you do receive an MCI diagnosis? Do you investigate further and insist on, I'm talking about MCI due to memory loss, and, maybe there's just, some scores on the cognitive tests are coming back with a bit of concern, but not anything, major. What should people do? Because a lot of times, they're told, okay, it's MCI, do your best and I'll see you in 6 months. So, do you have advice to people as to what types of questions they should be asking their doctor, and what should they be monitoring, or what should they be insisting on for further diagnosis? Because not every place is going to be a UCSF, right? Around the country and around the world for that matter. So what is it that we can give to people to understand really what they should be asking for?
Yeah, that's another really great point. I'll just, say a little bit of background about why oftentimes physicians will say, we'll hold on to this, come back in 6 months, we'll evaluate you again, because that's sort of the best marker to know if there's true change over time, is these repeat evaluations. That being said, I think, each patient's own individual experience also tells them whether or not there's been change over time. And being really clear, about that with yourself to say, okay, have I experienced these kind of progressive changes in my memory over time? Do I feel that it's really getting worse? And if you really do, be super clear and communicative about that with your doctor. Bring examples, tell them, specific reasons why these are concerns to you. And if that's the case, push for further evaluation. Any doctor that maybe is telling you to just, forget about it and come back in 6 months for a reevaluation, you can really push for these additional diagnostic tests. And, I think being aware of what exists is step number one, so that you can, know what to ask for.
So the scan, how does the scanning work? So is that standard care of practice? If you come in saying, I know you first give cognitive assessments, you understand if there's other things going on, but then would the patient be given an MRI right away, or what's the standard care of practice?
Not at all clinics, no. And you're right, UCSF is very different. We get brain MRIs on pretty much every patient that we see, but that's not a standard of care across the country and across different clinics with different resources. But you can advocate for that, especially if there's an indication, and your provider can refer you to get additional brain scans, get, these fluid biomarker tests through lumbar puncture, getting as much comprehensive information as possible for you to know what the next steps are, is really helpful.
The diagnostic tests, like let's say, and the blood tests are coming. We know that, right? I mean, they're coming. That's going to make it a lot easier for patients to see. But I have a question, because we know that there are people who have beta amyloid plaque in their brains who may never get Alzheimer's. And that's just probably a factor of, maybe they didn't hit the tipping point before they died and they stayed cognitively healthy. But is there a scenario where you would see plaque, like let's say like somebody had a PET scan or a spinal tap, and it was PET positive for beta amyloid plaque? Would that person ever just have an MCI diagnosis, or at that point would you say, okay, it's early stage Alzheimer's?
At that point, somebody could still absolutely have an MCI diagnosis. Again, the MCI is sort of separate from what's causing the cognitive impairment. So if there was evidence that there were beta amyloid plaques, at that point, the provider might say this is MCI due to AD, or due to Alzheimer's disease. And only until, a person progresses and can no longer complete those activities of daily living independently would it be classified as a level of dementia versus MCI.
Right. Okay. And we're getting a question in saying, when are these blood tests going to be available? So let's just take, you only know your own world. What is UCSF doing? Are you going to have blood tests available to people? I mean, I'm sure you're using them in some trials, right? Is that true?
Yeah. And actually we are starting to roll out blood tests for phosphorylated tau, which is an indicator of of Alzheimer's disease. So we are starting to roll it out. It's, it is more preliminary, but
I have a question. Why are you using them for tau and not amyloid? I'm just curious.
I know that it's a good question, but the research in blood is showing that these phosphorylated tau markers are the most indicative of Alzheimer's disease in the brain. There's lots of things that can affect what's in our blood, and it's not necessarily directly connected to our brain. So we have to find these markers that are more closely correlated with the things that are in our brain. And that's why, the lumbar punctures are have been the gold standard, because it draws the fluid that is directly surrounding the brain. So we're getting a closer, one-to-one connection with the brain as compared to blood. So we kind of have to find all these different markers that closely relate to brain.
So, but doesn't tau indicate a later progression of the disease? Like you start with the plaque, then you get the tangles?
Yeah, so the tau tangles represent a stage of Alzheimer's disease that more directly correlates with cognitive functioning, actually. But what people are finding in the blood is that our markers of tau in blood relate really strongly to amyloid in the brain. So there are lots of studies that are coming out now showing that these phosphorylated tau markers in blood correlate very closely to our amyloid PET scans and the level of amyloid that's detected via PET scans. And so people are really thinking that in the blood that these are markers of amyloidosis.
So I'm assuming if someone has tau, then you're going to say you have early stage Alzheimer's and not MCI, or no?
Well, again, I think the tau is another indicator that Alzheimer's disease is in the brain. And the MCI is just characterizing your level of cognitive impairment, regardless of how much protein or if any protein of Alzheimer's disease at all is in there. So someone could absolutely still have tau tangles and be characterized as MCI based on their level of cognitive impairment and level of functioning if they're still independent.
Yeah. We have a question coming in from Beth, who said, I have heard the lack of beta amyloid plaque in an LP may be indicative of Alzheimer's, not the presence. Is that true?
Yes, exactly. That's exactly right. So lower levels in our fluid indicate that more amyloid is accumulating in the brain.
So can you have plaque swirling around in your bloodstream, but it doesn't make it to your brain for whatever reason? Or if it's in your blood, will it be in your brain?
Well, the interesting thing is that actually everybody has amyloid. It's just a part of our normal functioning. There's amyloid in my blood, in everybody's blood. The problem is when it starts to aggregate in the brain. So that's, the aggregations are the plaques. And that's, because it's aggregating, it's not clearing from the brain. That's why we have lower levels in the fluid that indicate Alzheimer's disease plaques are accumulating.
Right. So I guess someone's asking here if it's a blood test in the brain, through the vein. Is that how? I mean, I don't know.
Yeah, exactly. It would just be a typical blood draw, like we would normally get at our PCP appointments to test any other, typical labs like our cholesterol. So it'd be, blood draw drawn the same way.
So if I go to UCSF with memory problems and I say, are you going to offer the blood test to everyone, or is it just for certain people?
So there are certain indications, for example, if somebody comes and we find that, they're performing pretty normally on testing and that there's a clear indication that there's something else driving this cognitive impairment. For example, a lot of times we get people with sleep apnea who don't know that they have sleep apnea and they're not being treated for it. And, it's really disruptive to their sleep and their day-to-day. We say, okay, let's treat that first. And then if problems persist, or if you're feeling like things are getting worse, then we'll explore these diagnostic tests through the blood or through the CSF.
So, okay, we have also another Chris Boyce, who's always a regular viewer of ours, and we appreciate him. Okay, the question is, I did the p-tau test 3 years ago in a clinical trial. They told me higher than normal levels, but being a clinical trial, they couldn't tell me what that meant. So I guess the question being, are there different levels of tau once you detect it, and is that associated with memory loss?
Yeah, that's a really good question. So, I mean, there is this issue in clinical trials where they're not allowed to give you information sometimes. I think there's a push away from that where there's
we hear about that all the time.
Yeah, exactly. We're all on board for sharing as much information with the people who are contributing to research as possible. That's the reason why research happens and advancement happens is because of people's participation. So we want to, give back. But to answer the original question, Depending on the exact test, there are cutoffs that people use to say whether or not it's an elevated or I just should say an abnormal value. And so there are, these sort of established cutoffs. And when it is an abnormal value, there's pretty good sensitivity and specificity to determine that Alzheimer's disease is present in the brain.
So should patients be insisting? I'm sure not everyone's getting like, oh, here, would you like a blood test? Should patients be insisting? I mean, obviously, if they're ready for that type of information, right? But do you think that it's, oh, sorry, I'm getting a call and I don't, from my daughter. Do you think that that's good enough? Like, should patients be insisting that, yes, I want a blood test if they really want to know that the beginning hallmarks are present?
Yeah, this is an absolutely individual decision. If somebody is really ready and determined to and wanting to know what, whether or not Alzheimer's disease may be driving their symptoms, absolutely, you're in control of your healthcare, and your provider should be supportive of helping you, achieve these healthcare goals. And if part of that is gaining more information about what's going on, then absolutely. I think oftentimes, as patients, we have to advocate for ourselves. So, I would absolutely, support anything that a patient wants to have more information on.
Are they covered by insurance right now? Do you know?
Some of the lumbar puncture ones are. I don't remember if any of the blood tests are currently covered by insurance. And
that's okay. I kind of put you on the spot without telling you.
No.
Like we're
okay.
talking a lot about the blood test because I think there's a lot of interest, but you're allowed not to know things because it's a very new technology. So Emily, give us a cheat sheet of, if you're experiencing memory loss, what are some of the other things that you should consider in order to determine whether or not, you mentioned sleep before, what else?
Yeah, I think we're thinking about a lot of different modifiable factors, right? So of course there are things that affect our other aspects of health, including, these cardiovascular risk factors. I think, a saying that we often say a lot is a healthy heart is a healthy brain. And so you really want to take control of managing things like blood pressure, cholesterol. If there's an indication for diabetes, you won't really want to get that under control. If you have any changes in mood, that can really affect how you function in a day-to-day life. Engaging in treatment for those sorts of things. Those can all be really helpful just in not only, improving your own day-to-day life, but in determining what is really going on. Because if I treat those things and it gets better, then maybe, that's kind of a good sign.
Do you see a higher association with maybe people with MCI, with people who are overweight or perhaps have diabetes?
Yeah, there's lots of studies showing that those sorts of factors are risks for developing cognitive impairment down the line. And the exact mechanisms for those things, people are still really digging into. I think there are both direct and indirect effects on the brain when we're thinking about things like diabetes, cholesterol, and blood pressure in particular. I think high blood pressure has, had one of the strongest correlations with future cognitive decline.
So I know it's interesting. All of this is getting so interesting because the more data we as individuals get about our own health, the more we could be proactive. And now you have all these monitors and things like that. So, I know that with diabetes, the risk goes up. Diabetes type 2, your risk goes up hugely. 75%, I was told, is like a chance of developing Alzheimer's if you are diabetic, diabetes type 2 for, a consistent period of time, a considerable period of time. So what If you are already experiencing memory loss, but let's say it's brought on by something like cholesterol or glucose levels, metabolism, that type of thing, do we know, is it like Alzheimer's where if the damage has already started in the brain, it's really hard to reverse, but maybe you could slow it down? Or in those cases with lifestyle factors, can we actually reverse that?
Yeah, that's a great question. So in some ways, some of the research that's been done in this area has shown that, once some damage has already been done, it is hard to revert that and improve from there. But treating those, medical factors and really getting those stable can stabilize your cognitive trajectory as well, and at least slow any decline. For example, if Alzheimer's now is on board, and your diabetes is way out of control, that could potentially accelerate the cognitive decline. But if you get your diabetes under control, your glucose levels are stable and really optimal, then that can slow that decline.
Okay, and then how long a period is MCI usually? I mean, MCI is like you're just experiencing. It typically in patients who are later diagnosed with early stage Alzheimer's after an MCI, what would you say the general time period for that is?
Yeah, it really ranges, and it's especially depending on what level of MCI people are sort of at. But it can range really anywhere from a year to a couple years. And there are so many factors that can influence this too. I work with a lot of people, including some of the research that I do at UCSF, showing that these lifestyle modifications can make a really big difference in the trajectory of cognitive decline. One of the most important things we often emphasize for people is staying physically active. Even something as simple as reducing your sedentary time, or the time you just sit all day, can be a step in the right direction. So there's quite a range, and it's because of some of these individual factors.
I've felt that firsthand. I'm a runner. I run usually almost every day, but I can remember things in my mind on my run. Like I've written speeches in my head, and it sticks with me and I can't explain it, but it's like whenever I have to do something hard, I go on a run, and for some reason my memory's better. And I was like, you can't deny that. It's happened over and over again, right? So that mechanism of memory and exercise, there's got to be a great connection there.
Oh yeah. And research shows that consistently, time and time again. Some of the people that I work with at UCSF too are really trying to dig into what are the biological factors that translates physical activity to these better brain health sort of outcomes. And I think there's a lot of really interesting things going on here in ways that we can tap into those biological mechanisms.
Okay, I would love to volunteer for that study. So sign me up. I've always wanted to do an exercise, because if you're exercising anyway, and frankly, I feel like I have a terrible memory. So, I would love to understand that. But actually, this is what I want to end on too. Baseline. How important is baseline to get an accurate? So, me right now, I might have a terrible memory, but I'm healthy and I don't have early stage MCI or Alzheimer's yet, knock on wood. But worry about that because I have a mom with Alzheimer's. Should I have a baseline? Then how do I get one? Do I just call UCSF and say, hey, I need a baseline? Or will they be like, no, we're too busy? Like, how do people get baseline cognitive assessments?
Yeah, I do think baselines are really helpful because everyone starts at a different level. And the best comparison is a comparison against yourself. However, you are hitting the nail on the head, because our clinics are often overrun and really busy. And, if someone calls saying that they don't really have any cognitive concerns, but just want an evaluation to know where they're at, that can be really difficult and potentially just not achievable, depending on the clinic. So, my recommendation would be, just keeping an eye on symptoms. And once you start to notice significant changes for yourself, that is the time when, the earliest decline, if we can catch you at a moment when you're having the earliest signs of decline, that can be a pretty close to baseline.
But what does a baseline assessment look like for a healthy person?
Yeah. So, again, I'm a neuropsychologist, right? I think about this in terms of, how a neuropsychologist would approach it, but it would be a comprehensive cognitive evaluation. Neuropsychological testing is done with people of all age ranges, from kids to adults, older adults. And so we would give, an evaluation that taps into all aspects of functioning like we would with anyone who's coming in with a specific complaint. You would note strengths and weaknesses, and then at a later time point, you'd have the, performance on each of these tests to compare to.
Okay, great. Emily, thank you so much. I've loved speaking about this topic. I think it's one that deserves a whole lot more time because it's impacting so many people and there's a ton of confusion around it. So thank you so much for really sharing your insights and your expertise.
Yeah, absolutely. I'm happy to chat about this anytime, and thank you so much for having me here.
If you guys have more questions for Emily, just send them to us. We'll pass them along. Don't forget to sign up for our newsletter on beingpatient.com. That's when you'll hear about what's coming up. We have a lot of great talks lined up like this one. So please join us. And thanks very much for your time today. Speak soon. Bye.